I think one of the reasons that the subtalar joint can get really stiff is because there's a lot of shear loads, but also a lot of compression loads when they load up the back of the ankle in just even a small heel rise position. So it gets quite compressed and it really loves distraction. So all of my subtalar joint mobilising involves quite a lot of distraction. So I've blocked the talus anteriorly. I'm using this leg to keep their ankle in plantargrade, but once I progress, I can actually use my leg to bring them into a bit of dorsiflexion. I'm cupping and I'm trying to keep it really comfortable, cup round the back of the calcaneus, and I use this hand to assist as well. So even though I'm doing a posterior to anterior mobilising of the subtalar joint, I'm doing quite a significant amount of distraction, and that's the key component. So we've blocked the talus is blocked, and we're doing an anterior translation of the calcaneus on the talus. Now again, I'm really feeling that range of movement. If they've got a bit of instability, it'll be quite excessive, but they might start off blocked and just need a very small number of repetitions of this. Whereas if it's truly stiff, then I'm really doing more repetitions and more vigorous and maybe a larger grade. Now with any synovitic joint, you don't want to be vigorously mobilising because it just adds some friction to the joint. So we want to do quite slow, heavy mobilising without frictioning that inflamed tissue. So once that's started to move, then I'll get them into a position where I can block that talus even more. So I use my knee behind their knee to block the thigh. I'm blocking the talus anteriorly and I'm cupping up underneath the calcaneus to give some distraction. So I'm gliding the talus posteriorly with this hand, and this hand is doing the distraction. Is that okay, Emma? Yeah. So we're getting some good, very localised posterior to anterior gliding of that calcaneus of the talus to free up any stiffness through that ankle. And as soon as I start to feel that it's moving in the ones that are a bit unstable, then that's enough. So you don't want to be doing that excessively and then causing even more instability. So this was our assessment technique for medial glide of the subtalar joint. And I like to do both medial and lateral. And again, I'm just gliding in. I'm really feeling like, feeling that the range of movement is blocked in this situation, but very carefully gliding in, not aggressively mobilising because I don't want to stir up any further synovitis. So same technique as my assessment, where I'm just gliding that calcaneus laterally. Now I've got my legs holding you in plantargrade, but if you're lacking some dorsiflexion, then I might add some dorsiflexion into that movement as well. So gliding laterally and then add a little bit of dorsiflexion. So this could be a part of your assessment and treatment, but often with an ankle sprain, the talus tends to translate anteriorly due to the lateral ligament damage. So I've got my fingers, you could sort of come around this way or have a towel to make it a bit more comfortable. I've got very used to sort of feeling where that subtalar joint is in neutral, so I'll use my leg to take you from pronation to supination, and then I'll just glide that talus posteriorly. So I'm on the neck of the talus. I've fixed the calcaneus into the bed, so this is a subtalar joint mobilising technique, and I'm gliding the talus posteriorly on the calcaneus. So I've got very used to sort of using my fingers there, but you can certainly glide it back with your full hand as well. So again, not aggressively mobilising because we're not wanting to add too much shear and friction to that joint, but gliding it back to see if that could be limiting your dorsiflexion range of movement.